Hey guys, welcome to my YouTube channel. Let's revise medicals. Today we are going to discuss disorders of respiratory system in pediatrics. So, the respiratory system disorders are mainly classified into two types, acute and chronic. Out of which, acute is further classified into upper respiratory tract infections and lower respiratory tract infections. Respiratory tract infections include acute tonsillopharyngitis and nasopharyngitis, whereas lower respiratory tract infections include croup, pneumonia, bronchiolitis, bronchial asthma, foreign body aspiration. And chronic respiratory tract infections include lung abscess, empyema thoracis, cystic fibrosis, and acute respiratory distress syndrome. We'll start with nasopharyngitis or the common cold. Common cold is most frequent illness and is caused by adenovirus, influenza virus, rhinovirus, para-influenza virus, and respiratory syncytial viruses. And these spread by droplet infection. So, what is the patient present with? The patient presents with fever, thin nasal discharge, and irritability. He may also have cervical lymph nodes enlargement. Patient may also complain of nasal obstruction if the etiology is of allergy, that is, in allergic rhinitis, the patient presents with clear mucoid discharge with sneezing, and he does not give any history of contact with the infected patient, and history of allergy is usually present. Wheezing may occur in these cases. There is presence of dry hacking cough. There may be excessive lacrimation and the nasal discharge. If it gets secondarily infected, it may become more purulent type. If the allergic origin, the illness lasts for 2 to 3 days, but if cold, the illness may persist up to 2 weeks. So, what are the complications? The complications of nasopharyngitis are due to nasopharyngeal congestion like otitis media. The other complications are laryngitis, sinusitis, bronchiolitis, bronchopneumonia, and exacerbation of asthma. So, what are the differential diagnoses? First is nasal foreign body, but here the patient presents with unilateral discharge from the nose, and second is snuffles. In snuffles, the patient or the newborn presents with clear mucoid discharge from the nose in first few weeks of their life, but snuffles of congenital syphilis is rare and it causes bilateral discharge, excoriating the upper lip and leaving fine scars. Moving on to treatment. So, in treatment, we give drugs to relieve the nasal congestion, to reduce the fever. We give cough syrups, antibiotics. To relieve the nasal congestion, we give nasal decongestants like ephedrine, xylometazoline. Nose drops of saline gives symptomatic relief. Antihistaminics given they dry up the secretions and relieve sneezing but should be avoided in the first 6 months of life. And newer non-sedating agents like loratadine, cetirizine are useful in allergic rhinitis. For fever control, we give antipyretics such as paracetamol. We give cough syrups to suppress the cough. However, they should be avoided in infants and children as the mucoid secretions retain and predispose to spasmodic cough, wheezing, atelectasis, and suppuration. Antibiotics, they are of little value in viral infection, and these are used if the secretions further become purulent, which indicates secondary bacterial infection. Nursing care includes like protection from sudden exposure to chills, feeding continuously to maintain the hydration. Second, acute tonsillopharyngitis or sore throat. So, it is the acute inflammation of the pharynx and tonsils and is usually viral in origin, but it can also be bacterial. If viral in origin, viruses like adenovirus, influenza virus, parainfluenza virus, enterovirus, and Epstein-Barr viruses are mostly involved. Other causes are streptococci, mycoplasma pneumoniae, candida albicans, measles, and rubella. Clinical features. Clinical features like the patient presents with fever, malaise, headache, nausea, and sore throat. Here, we need to differentiate between the viral and the streptococcal origin. If the origin is viral, symptoms like hoarseness, cough, and rhinitis are common. The onset is gradual and there is less toxemia. Whereas if the origin is streptococcal origin, cervical lymph nodes enlarge and the patient presents with high fever and exudates over tonsillar surfaces are present. There is no nasal discharge or conjunctivitis. What are the complications? Complications due to the infection spreading down to the tracheobronchial tree and causing tracheobronchitis and pneumonia. If streptococcal sore throat, it may later present with acute rheumatic fever and acute glomerulonephritis. If the origin is streptococcal origin, we need to treat it as soon as possible. So, how to diagnose? The possibility due to A beta hemolytic streptococci should be considered if the patient presents with fever, exudates in throat, tender enlarged cervical nodes, and absent nasal or conjunctival congestion. If throat culture is done, it helps in definitive diagnosis. Other diagnosis like neutrophil count is elevated can be considered. However, rapid diagnostic tests are not frequently available. Treatment: we give paracetamol for fever. Soft food is given as the patient is unable to swallow or it is painful. Warm saline gargles are prescribed for older children. Younger children are given warm tea. If the origin is viral, antibiotics have minimal role in it. But if the infection is with beta hemolytic streptococci, we treat it with penicillin, orally, injections of procaine penicillin or oral erythromycin for 10 days. We give this 10 days therapy, and if there is any compliance problem, a single intramuscular benzathine penicillin is given. However, cotrimoxazole and fluoroquinolones, which we give otherwise, should not be used in these patients. We should further ask for recurrent attacks of sore throat by taking a detailed history, and we should examine paranasal sinuses and ear for the same. Patients should avoid smoky, dusty atmosphere, damp environment, and overcrowding. If suspected of bacterial pharyngitis, every episode should be treated with antibiotics for at least 10 days. Third, pneumonia. Pneumonia is an inflammatory process. It involves the lung parenchyma. Pneumonia, it results from aspiration, continuous spread of agents, secondary infection, and hematogenous spread. So, pneumonia can be classified mainly on three bases: anatomical classification, which involves either the pneumonia can be lobar or lobular, in which one lobe is mainly involved. In interstitial pneumonia, it is characterized by massive proliferation of alveolar cells and the desquamation. Third, bronchopneumonia. It involves terminal bronchioles as well, and multilobar pneumonia. Classification based on duration of symptoms. It can either be persistent or recurrent. Persistent, we say if X-ray abnormalities are present for more than 4 weeks, whereas we say it is recurrent if two episodes of pneumonia occur in a year or three or more occur at any time with X-ray clearance between the two episodes. Classification based on etiological factors. It can either be infective or non-infective. Infective results due to microorganisms such as bacterial, viral, whereas occurs mainly due to chemical, that is, pneumonia is referred to as pneumonitis when the cause is non infective. Infective pneumonia can further be of three types: bacterial, atypical, and viral. Bacterial pneumonia, the etiological agents are Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus, Mycobacterium tuberculosis, Pseudomonas aeruginosa. If the causative organism is atypical, it includes Chlamydia, Mycoplasma, Legionella. If viral pneumonia, the viruses include respiratory syncytial virus, parainfluenza virus, influenza virus, rhinovirus, and adenovirus. So, how do we differentiate between the bacterial and viral pneumonia? The onset of bacterial pneumonia is abrupt, whereas of viral pneumonia is gradual. In bacterial pneumonia, the infection at other sites is also present, and we see generalized septicemia, whereas viral pneumonia is associated with upper respiratory tract infections and coryza. Bacterial pneumonia, the fever is high grade, whereas in viral pneumonia, the fever may be present or may be absent. The patient is generally toxic if the origin is bacterial, whereas the patient is normal if the origin is viral. The lung, the lung signs in bacterial pneumonia are crackles are present, whereas in viral pneumonia we see wheeze. Based on the immunity, the patient can either have primary pneumonia or secondary pneumonia. Primary pneumonia is caused by organisms which are highly virulent, whereas secondary pneumonia occurs with organisms which are of low virulence. As the immunity is diminished or some other predisposing factors are present. There is this last type that is based on the source of infection. The pneumonia can be community acquired, hospital acquired, or opportunistic. Community acquired pneumonia can either be typical or atypical. Typical includes streptococcus, haemophilus, staphylococcus, whereas atypical include mycoplasma, chlamydia, legionella. In hospital acquired pneumonia, the main causative organisms are E. coli, Pseudomonas, Proteus, Klebsiella, whereas opportunistic pneumonia, the organisms are Pneumocystis carinii, cytomegalovirus, and varicella zoster virus. There are certain predisposing factors. Like host factors include if the patient is below 7 months of age, other factors like if the baby is preterm, low birth weight baby, congenital defects such as cleft palate or tracheoesophageal fistula or lung cysts. Other factors like nutritional deficiency like protein energy malnutrition, vitamin A deficiency if it is severe, iron deficiencies, anemia, zinc deficiency, and other factors. Environmental factors include overcrowding, indoor air pollution, and passive smoking. So, how does the patient present with? The patient presents with fever, cough, poor feeding, irritability, excessive crying, fast and difficult breathing, chest pain, and abdominal pain. What do we see? That is, what are the signs? Tachypnea, chest retraction, grunting, stridor, nasal flaring, cyanosis, dullness and percussion, diminished breath sounds like wheeze and crackles may also be heard. So for diagnosis, we do X-ray chest, CBC, and other tests to identify microorganisms like microscopic examination like gram staining and acid fast bacilli staining, serological tests, urine antigen test, rapid antigen detection test like direct fluorescent antibody test, bacterial and viral culture for sputum. Treatment. In treatment, we classify the pneumonia clinically and management as per ARI control program are variable. Antimicrobial therapy is given and supportive treatment measures are included. Supportive measures like oxygen administration, intravenous fluids, good nutrition, physiotherapy, avoiding predisposing factors, and if fever is present, then tepid sponsing should be done. Antipyretic like paracetamol should be given. Specific antimicrobial therapy, like if the patient is a neonate and if streptococcal or E. coli is suspected, we give ampicillin and gentamicin. If staphylococcus, we give cloxacillin and gentamicin. For infants between 1 month to 1 year of age, and if we suspect streptococci, we give ampicillin and gentamicin. If Staph aureus, we give cloxacillin, gentamicin. If Haemophilus, we give penicillin or ampicillin. And if Streptococcus pneumoniae, we give penicillin. For children more than 1 year, we give penicillin, metronidazole, ampicillin, cefuroxime, and ceftriaxone. We'll discuss further topics in next video. Until then, keep revising.